I'll give you introduction. I'll give the introduction.
Yeah, okay.
Good afternoon, everyone. It's my great pleasure to invite Dr. Vanessa Moll, Chief Medical Officer of Potrero Medical and Associate Professor of Critical Care Medicine at Emory University School of Medicine, to our lecture series, which aims to foster a spirit of innovation and entrepreneurship. The title of the talk is Innovating Bedside Kidney Monitoring, More Than a Gut Feeling. Dr. Vanessa, thank you very much for your time today, and we look forward to hearing from you. Thank you.
Excellent. Thank you so much for the very kind introduction. Hello, everybody. I'm super excited to be talking to all of you today. And I usually live in the US. I live on the West Coast in California between Santa Barbara and Los Angeles. But I'm speaking to you today from my old children's room. So I'm actually in close to Hamburg in Germany at my parents'. So this is quite funny for me to be talking to you from my old desk, but I'm very excited to be here, and please ask any questions at the end. I think that probably will be easier to do it at the end than in the middle of the talk. I tend to talk rather fast, so I will try to pace myself during the talk. If I speak too fast, please just let me know. So as already mentioned, I'm the Chief Medical Officer for Potrero Medical, and I will tell you a little bit more about Potrero Medical in just a little bit. I am also a clinician. I'm an anesthesiologist and intensivist. I trained in Germany and then retrained again in the US. And I worked in Europe, Germany, Switzerland. I worked in Africa and also in the US. And I now serve as the Chief Medical Officer for Potrero Medical, but I also remain active at the bedside. So in this presentation, I will take you through the scientific work we are doing at Potrero, and I will also share some insight and lessons from my work at a startup. All right, so this is a little bit experimental. This is my first interactive presentation using a polling system. So please take your cell phones and scan in the QR code. And then I have a question for you. Okay, so and what is your medical specialty or job description? And don't feel shy. Hopefully the QR code is working and you can just type in what your specialty is or your job description. Are you training to be a nephrologist or internal medicine, surgery? Okay, we have internal medicine. Fantastic. The poll seems to be working. I'm just going to give you a little bit more time to answer. So it seems like the size of the font is weighted by, oh no, there we go. It's going to be a cloud. Oh, fantastic. Intensivist, hospitalist, pediatrics. Oh, excellent. A little bit of everything. Oh, very cool. Okay. Oh, a chemist, a consultant, nurse, pathologist even. Wow, okay. And then ID, infectious disease specialist, preventionist. Oh, excellent. Well, fantastic. That is very exciting to have such a diverse crowd listening in. Thank you, everybody. Okay, I'm gonna go ahead now and dive into the talk then. Hopefully there's gonna be a little bit for everybody. So this is how my story with industry started. I was directing the cardiovascular intensive care unit at Emory University Hospital Midtown in Atlanta when I learned about a bladder catheter on steroids, continuous digital urine output monitoring, and intra-abdominal pressure. It took me 2 years of back and forth communication with the company Potrero before I started the first pilot trial using their monitoring devices in my cardiac surgery patients. Now I know that the company in 2016, back then, just needed more time to get ready for clinical research. Now we are. In our first observational trial, and this is data from 2018 in Atlanta, we included 27 patients. Much to my surprise, a majority of patients developed intra-abdominal hypertension post-cardiac surgery. This little pilot trial was the start to a collaboration with Potrero, a new research interest, and a large observational study in cardiac surgery patients. With about 1,200 patients in our database now, we are currently preparing for our first analysis, so stay tuned. And in this first pilot study, I could associate the development of acute kidney injury stage 2 with the time spent in high intra-abdominal pressures above 20 millimeters of mercury. Okay. So, okay. Here we go. Okay. Let me quickly show you what makes the Accurine special. First, it has an active drain line clearance that you can see here. There are no airlocks that prevent urine flow. The urine you see coming out of the patient or in the drain is the urine produced by the kidneys. Second, the catheter has besides the big retention balloon, has a smaller balloon, an additional balloon that is connected to a smart sensor. And that's how we can measure intra-abdominal pressure. And this is really a game changer compared to the manual hydrostatic column measurements that we only did really before, when we absolutely anticipated and really suspected intra-abdominal hypertension. So the monitoring system consists of the smart Foley catheter that I just showed you, the Accurine monitor, and then an acute tab. And this tablet was designed during COVID because nursing and clinicians really couldn't go to the bedside, and they were putting these acute tabs outside of the patient's room so they could see intra-abdominal pressure or urine output monitoring without entering the patient's room. And we still have these acute tabs, and in the next version of the Accurine monitor, the big acute tab will actually fit onto the Accurine monitor, and then it can detach and you can take it off, and there will a monitor will remain on the Accurine monitoring system. So let's dive into the science. What is intra-abdominal pressure? What is intra-abdominal hypertension? Normal intra-abdominal pressure in critically ill adults is about 5 to 7. Intra-abdominal hypertension is defined as a sustained intra-abdominal pressure above 12 millimeters of mercury. Abdominal compartment syndrome, or ACS, is defined as a sustained intra-abdominal pressure above 20 with new organ dysfunction or failure. And then intra-abdominal hypertension is graded by the level of intra-abdominal pressure. High IAP or intra-abdominal pressure affects multiple organ systems, as you can see here. Basically from the head, really from top down, from the head down to the muscles. Examples are the brain. High intra-abdominal pressure can affect intracranial pressure, it elevates it. It affects the heart. Intra-abdominal hypertension leads to low cardiac output, or it can affect the kidneys. Intra-abdominal hypertension can result in acute kidney injury. How often do you really see intra-abdominal hypertension in the ICU? There's multiple studies from mixed ICUs, cardiac ICUs, that's Delfino, medical ICUs, surgical ICUs, and the incidence really varies from 30 to almost 50% of patients who develop intra-abdominal hypertension. Besides the increased morbidity that we saw on the past slide, it also increases the mortality. When you develop abdominal compartment syndrome, that leads to the highest mortality, which is not surprisingly. So let's focus on the kidney. This is an editorial that Manu Malbrain wrote together with Drs. Roller and Dabrowski. And Dr. Malbrain has been studying intra-abdominal hypertension probably for the past 35 years. So he is the world-leading expert. The pathophysiology of AKI is complex, as you know, and it has not been completely elucidated. We know that elevated intra-abdominal pressure leads to compression of the vena cava, causing reduced venous return to the heart. This decrease in preload reduces cardiac output and thereby reduces blood flow to the organs, including, of course, the kidneys. Oliguria, so low urine output, may be one of the earliest signs of abdominal compartment syndrome. Intra-abdominal hypertension also reduces renal blood flow and glomerular filtration rate through the compression of the renal veins and arterial vasoconstriction. This then in turn leads to an activation of the RAS system, the renin-angiotensin-aldosterone signaling cascade. Additionally, intra-abdominal hypertension triggers an inflammatory response that may also add to the development of acute kidney injury. So there's multiple pathways for intra-abdominal hypertension to add to an insult to the kidney. Acute kidney injury itself is a major problem in our hospitals, not only really in the ICUs, but also on the floor or normal wards. AKI itself is common, with about 60% of patients in the ICU developing at least one episode of AKI during their stay. Acute kidney injury is also associated with an increased mortality and, of course, higher costs to the healthcare system. Unsurprisingly, multiple societies have taken action and taken up the challenge to develop guidelines to tackle the problem of acute kidney injury. I think most known are the Kidney Disease Improving Global Outcomes Consensus Guidelines for acute kidney injury. This KDIGO or KDIGO bundle includes the avoidance of nephrotoxic agents, including radiocontrast, monitoring and optimization of hemodynamics and the fluid status, glucose control, and close monitoring of urine output and creatinine. We all think that we are practicing all these elements of the bundle together at our institutions, but are we really? So here's the next poll for you guys. Please scan in the QR code, and I have to activate. Let's see if this works. I have to activate this. Okay, here we go. I think the link should be active now. Sorry for the delay. I'm learning with you. All right, so less than 1%. Oh, that disappeared. Here we go again. Okay, less than 1%. I'm going to give you a little bit more time to see if everybody agrees that it's really not used at all. Okay, anybody else wants to answer? Okay, here we go. 50%, 25%. Any takers for above 90%? All right. So we're at 50%, less than 1%, and 50% of you think it's 25 to 50%. So let's see what it is. A recent multinational survey asked the question how often the KDIGO bundle is applied in the cardiac ICU. Quite shockingly, and 50% of you were completely correct. The bundle was applied to only 0.4% of patients. Close monitoring of urine output and serum creatinine was achieved in only 6%. About 60% of patients underwent optimization of volume and hemodynamics. But this, to me, was very surprisingly, really, that the bundle, which is not that difficult to apply to our patients, is not used in the vast majority of patients. So the next question then becomes, are all elements of this bundle created equal? Well, obviously, this is a very leading question, and so no, they are not. A sub-analysis of the PREF-AKI study, and just quickly, the PREF-AKI study looked at the application of the KDIGO bundle in cardiac surgery patients. And the result was that with the application of the KDIGO bundle, cardiac surgery associated AKI could be reduced. So the bundle works. Not only in cardiac patients, but also in mixed surgical medical patients, as seen in the Big PAC study. So this sub-analysis now showed that the hemodynamic optimization trumps other components. So the avoidance of hypertension, for example. This is not too surprising to us, as we know that even short periods of hypotension in the operating room or in the ICU can increase the odds of acute kidney injury, or, as seen here, the odds of myocardial infarction. We usually target a MAP of 65 millimeters of mercury, but is 65 really the right threshold? In this large database study from Maheshwari et al., the odds for mortality and AKI increased with blood pressures lower than even 85, as you can see here. Not so much for myocardial infarction, but you can see the impact on acute kidney injury or mortality. So maybe the map itself is just not the right target. Should we be rather aiming for optimized perfusion pressure? The mean perfusion pressure or abdominal perfusion pressure or renal perfusion pressure, so MPP or APP or RPP, is calculated as the mean arterial pressure, the MAP, minus the central venous pressure, CVP, or intra-abdominal pressure. And here the circle closes. This is an Australian study from a couple of years ago, 3 years ago. The Panwar and his colleagues studied patients, 302 patients from 5 mixed ICUs, and showed that mean perfusion pressure deficits increase the odds of acute kidney injury. And this study was very interesting because they defined as the mean perfusion pressure deficit as the difference between the patient's pre-illness basal perfusion pressure. So they actually looked into the chart from their PCP. What is their normal at-home blood pressure? And so they looked at the difference between the basal pre-illness mean perfusion pressure and then the achieved perfusion pressure in the ICU. This study used CVP to calculate the mean perfusion pressure. But what about intra-abdominal pressure? Is intra-abdominal pressure maybe better than CVP to calculate abdominal perfusion pressure or renal perfusion pressure? This is a preclinical study that we did a couple of years ago in pigs. So this is a porcine model. And what we did is we measured intra-abdominal pressure and central venous pressure simultaneously, and volume fluid resuscitated the pigs. And in red here, you can see that the intra-abdominal pressure responded well to the fluid load, but the CVP in purple did not correlate with the fluid status. From our first publication of the Accurant study, we know that intra-abdominal hypertension is common in cardiac surgery patients. 20% of cardiac surgery patients spend at least 10 consecutive hours with an intra-abdominal pressure of about 20. Now I'm speculating, but what if these patients have a MAP of about 70? Then their perfusion pressure would only be 50, so 70 minus 20, which might not be enough for the kidney perfusion. A critical abdominal perfusion pressure or renal perfusion pressure is usually seen at about 60 millimeters of mercury. So anything below that likely is not beneficial for the kidney. We're working on a machine learning algorithm currently to predict acute kidney injury. And this algorithm uses continuous intra-abdominal pressure as the major component. Currently, we can predict acute kidney injury in cardiac surgery patients 41 hours before the event, giving us clinicians, hopefully, enough time to optimize the patient. On this slide, you see the first algorithm that we published at the AKI CRT conference a couple of years back. With the first algorithm, our predictive time was 1 day and 9 hours, so about 33 hours. And so with the updated algorithm and the inclusion of a larger training set, we are now at 41 hours, and we got a breakthrough designation by the FDA for this algorithm. And for you might not know what that means. It means that the FDA grants you access to the FDA for 2 years to really refine the algorithm and make it fit for FDA approval commercially after. So this was a big deal for us. So I'm leaving you now for this first part of the presentation with the question, should we target perfusion pressure? Or as differently as Marlies Osterman and her colleagues did, is MAP of 65 a target of the past? I will now shift to sharing some insights of my path from academia to industry. And we will start another survey. Get your cell phones out and ready, and please scan again. Oh, and let me try to activate. The poll. Okay, the poll is now active. And by the way, this is all anonymous, so nobody can track you. You can answer truthfully. Don't be shy, everybody. Okay, so we have maybes. I'm going to wait a little longer. I think there's always a little bit of a delay. I'm waiting for the yeses and nos. Unfortunately, I cannot see how many people answered. Nope, I cannot see it on my app either. Okay, so I guess we'll stay with maybe. You know, why not? Who doesn't want to leave their job if the opportunity is hot? Okay. Okay, I'm sharing with you pictures from the time of the pilot study that we did in my CVICU at Emory. On the left upper hand corner, I'm sitting with Jeff Alvarez, and we are shifting back and forth little post-it notes. And I can still remember what he was asking me. He was asking me if I could measure electrolytes or other compounds in urine. What would it be? What would be helpful? And this cassette here, there is space, for example, built-in space for a camera. So you could potentially look at density or the color of urine. And one could potentially put in a system to look at electrolytes, for example, sodium, which might be very helpful. Look at this stand. This is what the stand initially looked like when the Accurant came to my ICU. And yes, you're seeing right. This is a guitar stand. So they didn't have, the company back then did not have their own stand. It was a guitar stand. And as you might imagine, a guitar stand is not holding up the pressure and the weight of the bed. So within a day, 2 of these stands broke. And luckily, my nurses were, this is a little bit later, but my nurses were so kind to give a lot of good feedback and insights to make the Accurant system better and make the stand better. And so now the stand withholds large forces. So here, one of my colleagues is jumping on the new Accurant stand and uses it as a stool. This is our CEO, Joe, and this is Joe and I believe in my office at Emory. So the New England Journal of Medicine has a career center, and they oftentimes have articles about outside or non-clinical work opportunities. They do not only write about clinical medicine. So this might be also a good resource for you to look at. I'm working for a late stage startup, Potrero, but there are many other non-clinical opportunities for physicians, be it in hospital leadership or health insurances, for example, or in pharmaceutical industry or the medtech industry that I'm in. Especially now with the developments of healthcare artificial intelligence, opportunities exist for clinicians to help coders and data analysts develop algorithms that make clinical sense. For example, coders and data scientists do not know that procalcitonin, for example, is not a routine measurement everywhere. So while the algorithm that they built with procalcitonin might show higher sensitivity and specificity, but it doesn't make sense for us clinicians because it is not routinely measured. So clinicians like us come in to really guide data scientists and what makes sense and what does not make sense. When I think about mindset differences in industry versus academia, it basically goes like this. In industry, how well can your team work cross-functionally to achieve the common goal? And then in academia, how do you move projects forward on an individual level? So it is basically a group thing versus really only individual. When you look at yourself, you bring a lot of strength to the table. You are an asset to industry. You're problem solvers. You think critically. You know how to present. You know how to manage projects. You have the bigger picture, the bigger clinical picture in mind. You have research skills. These are all skills that are looked for and sought after in industry. It is important to follow your interests to find non-clinical opportunities. Passion and expertise in an area lead to success. Networking with industry at conferences brings opportunities to connect. You can get your feet wet with projects, consulting work, or industry-funded research before taking the leap of faith. Maybe one last comment though. The grass always seems to be greener on the other side, but that's not really true. So don't fully quit your clinical work. Your clinical expertise is your asset, and your network makes you relevant to industry. It gives you a standing with clinical colleagues and is your safety net should industry not pan out. What are skills learned that I can transfer? And I picked 3 skills that I use in my clinical practice that I think are very relevant. So there's the elevator pitch. How to sell your vision and your ideas. An elevator pitch is a brief, about 30 seconds way of introducing yourself, getting across a key point or two and making a connection with someone. It's called an elevator pitch because it takes roughly the amount of time you would spend riding an elevator with somebody. Elevator pitches are handy to have in mind anytime you are at an event where you might meet prospective job or networking connections. And the elevator pitch, especially in the startup world, is extremely important. You need to find investors. Investors usually do not have really any idea about the clinical problems that you are solving. They're usually not healthcare providers or clinicians. So you need to sell them an idea within 30 seconds. Make it palatable, make them interested. Once they ask questions, you already have them half wrapped around your finger. Then setting goals. Setting goals is also, I think, an art and very important for career development. We know SMART goals. SMART goals are specific, measurable, achievable, relevant, and time-bound. And we usually use SMART goals for our personal goals. For team goals, I use OKRs, objectives and key results. They work fantastic. They were invented by Google, basically, and Google started them in 1999 with 40 employees. And fast forward in 2017, and even now, they're still using them with 70,000 plus Google workers. So what are they? Objectives and key results are a team-based goal-setting methodology that can help you set challenging and measurable goals. Objectives help you articulate what you want to achieve, and key results explain how you will achieve them. Very important components of this methodology are the feedback culture. It needs to be transparent, and it needs to inspire. So your goals need to inspire. They should be moonshot. So you should not be 100% achieve them, but maybe only 80%. And they're really team-based. So they pull in everybody that belongs to the team. They need to be addressed rather often. So in industry, usually it's quarterly, but every couple of months or so. Design thinking is, I think, very helpful in healthcare. It's my third learned skill. Design thinking is an approach that prioritizes developing empathy for users. Working in collaborative, multidisciplinary teams, you see there is a sort of a red thread with the OKRs and design thinking. It's the collaboration and the multidisciplinary teams. And using action-oriented rapid prototyping of the solutions. And this is an iterative process with innovation emerging only after cycling through several rounds of ideation, a little bit like the plan, do, study, act cycles that we know from quality improvement, and then prototyping and testing again. And this really distinguishes it from the traditional linear and often top-down approach to health intervention design. So this is not top-down, but this develops an empathy for the user. What does the end user think? So our patients. This has patients in mind. This has clinicians in mind. Anybody using the new protocol or the new prototype. So that's it. Those are my top 3 skills. And now I'm closing my talk with a quote from Chris Grosser. And Chris Grosser is he's an advisor to Tesla, the car company. Opportunities do not happen, you create them. So thank you for listening and participating in the polls and really being my guinea pig with the polling system. And I'm happy to answer any questions that you may have. Thank you so much.
Thank you very much, Dr. Vanessa. That was a beautiful talk, actually. If I could share my personal story, my wife has a startup, and she gave me that book, Measure What Matters by John Doerr, the OKR slide. And that was, for me, a huge different way of thinking. Um, like you said, healthcare is mostly linear and top down, and we just follow legacy systems. But if you want to build something new or want to work on exciting projects, you have to have a different way of thinking, actually. I love those slides about design thinking, and I'm going to copy that in my next talk I gave, actually. Thank you very much, Dr. Vanessa. So while if the colleagues who are in the call, if they want to ask Dr. Vanessa any questions, please share in the Q&A, and I will put it to her. So Dr. Vanessa, I have some questions for you. What would Dr. Vanessa, the CMO, advise Dr. Vanessa, the resident, she should have done to accelerate her career or not go through the same challenges you went through to reach where you have reached?
Yeah, that is a fantastic question. I think I have probably at least two things that I would change if I could redo it again. One is focusing early on what you're passionate about. I'm a very curious person, so I have dabbled in a lot of different things. My PhD is in neuroscience. Then I did a lot with regional anesthesia in the ICU. I did pharmacokinetics and dynamics, and during my postdoc research. So a lot of different fields before I figured out what I really wanted to do. And I think it took me a lot of years, probably a decade, to figure that out. Going back, I think I would try to figure out what I'm passionate about earlier in life and focus on that and really build an expertise around that topic. So it could be, you could think hemodynamics. I mean, that's a broad topic, but it's more focused than having neuroscience, regional anesthesia, and 10 other things. And that way you can really build your expertise, you can publish, you will become very interesting to industry or other outside the hospital players. And you will become an expert to your hospital system and to your societies. The other thing I would encourage everybody to do is you have societies that do great work, and societies help you network within a community. Those are your people. Be active in the society early on. I also had a late start to the societies. And I think it's very beneficial to be to start being active as a resident and really network. That gives you the opportunity to find mentors. And that would be my third point. Find a mentor early on. And you do not only need, you're not looking for one mentor. You can have multiple mentors. And the mentors don't have to come from your field of expertise. So if you're in nephrology, your mentors don't all have to be nephrologists. You can have mentors in different specialties. You can have mentors in science. You can have a mentor in industry. And so building up a mentor system, so to say, I think is very valuable. Mentors will eventually become sponsors, and through these sponsors, you will have opportunities to advance projects. So I think that that is that's very necessary for budding careers.
Thank you, Professor. Another main key lessons is networking, meeting people from across disciplines, and then finding mentors and sponsors. Well, that's very insightful. Dr. Vanessa, healthcare is still a very old man industry. You are not the typical healthcare leader, phenotypically. How do you overcome imposter syndrome? Because as we've discussed, mostly my residents are women, and this talk is just to try and motivate them to think big and do big things. How do you overcome the imposter system? How do you feel that you belong where you are there?
Yeah, that is another fantastic question. I have to admit that I at times also still suffer from the imposter syndrome. I think nobody is free of it, and us women especially tend to have imposter syndrome. Although we have reached many milestones and have exceeded and maybe broken glass ceilings, I think it's it's unfortunately still an inherited thing from upbringing, society, and whatnot. So I oftentimes just rationalize my way out of it and talk to my colleagues about it. I think we might, it's difficult to be completely free of it. So I get that. Mentors really help. Role models. When I first did my residency in Germany and in Hamburg and Berlin, most of my higher ups were men, and still in healthcare in Europe and in the U.S. Most people in leadership positions are men. So we women have to work together and to elevate each other. And I think what is very helpful is finding mentors. You do not have the role model to look up to in your own institution. There are role models in national or international societies. There are role models maybe in research. There are role models in other hospitals that you can make a connection with and reach out to. I think it is so important to have a role model and to be connecting with other women. For us now, speaking as a woman, connecting excuse me, with other successful women to share experiences and learn from their experiences. So I think together we are a force, and we need to elevate each other. And if you would like to talk offline to me, or are in need of a mentor or interested to talk further, I'm here to help. So just shoot me an email, and we can connect, and I can also help to connect you to other role models if you wish so.
Thank you very much. I think you answered two parts of that question actually. That's very helpful. I think the main thing is to increase your network, so you see other people who are going through the same struggles, and you pull in resources and solve problems. So Dr. Vanessa, one last question, which you are working on a commercial project, but working in academic center as well. And normally in academic centers, thinking of making money for yourself is looked down upon. How do you overcome that? Of course, you did the basic science, you're going through scientific processes, but the question always being asked is, how are you benefiting yourself in the academic centers? How do you overcome that to create the company you've created?
Yeah, very good question again. Working with industry in the past was really frowned upon, and any papers you read that were funded by industry, you would basically say, oh, well, it's industry funded, so whatever the outcome is, it's not valid because somebody paid for the research. I think that mindset is shifting now. There is not a lot of public funding, such as NIH or so, and academia works slow, as you probably see in your institution as well. And so we need to build relationships with industry to move medicine forward. The approach needs to be collaborative. We need to learn from each other, listen to each other, and we need to incorporate skills from industry into our academic practices and skills from academia into industry. I think one great example is we saw during the COVID pandemic, the development of the vaccines in such a fast pace was only possible because industry worked with academia hand in hand. And so I think we all need to have an open mind and collaborate. How do you marry the two, academia and industry? I think you have to work to get your niche, and then also you don't have to. I for example don't work 100% in my clinical in the hospital system, but I work 80-20. So I think you can buy your time, and you can also make sure that academia sees the benefit of your industry work, and you bring in the end, you bring in money for academia to do research and to support research coordinators, research assistants, and to really further science and medicine. So I think it is a win-win situation, and the old school thinking of industry is really bad, and it's the good world versus the bad world is a thinking of yesterday, and we need to really collaborate.
Right. Thank you, Dr. Vanessa, for these excellent talk. I mean, these talks are recorded. Is it possible for me to share this talk with the other residents who couldn't join? Is it possible? I could do that?
Yeah, of course. Yes.
Thank you very much. I think so. Your email, will share with my residents who are interested to get in touch. I found this talk very interesting, and actually, like you mentioned, most of my best ideas come when I listen to other people. Because in my own field, we talk about the same concepts, but when you have these interdisciplinary discussions, I'm sure you've learned loads by working with your engineers and where your business people, marketing people, how to evolve your product. It was a great time, and I thank you again for your time today. Okay, thank you.
You're very welcome. Bye-bye, everybody.